This is kind of exam for me. It makes me bit nervous because of the first time speaking in front of my teachers, my seniors, my dad, and lot many people who put in their effort of making of what I am right now. So it gives you butterfly in the stomach, and at the end of the day, I want to make them feel proud on me. We'll start with what's new in the field of sepsis. So I'm waiting for this kind of moment to come in my life when, yes, I can run naked out of my bath and say, yes, something new has come. When I prepared this topic for the first time, when I was DM junior resident, I stole a couple of my slides from my senior's presentation. As I matured, I realized that my senior stole it from his senior, my senior stole him from his senior, and he has stolen it from his teacher. So practically, I want to live the day where I can see something new as like this, and you can see a couple of our colleagues run amok naked in the streets. But the more we realize that we go ahead and ahead and ahead, we want to come back. So we want to come back and we want to rethink that what have I done since so many years. So what I have done since so many years is sort of reinventing the same thing again and again. Okay, so now my understanding, my approach, the way we see our old friend and foe, neonatal sepsis, in a very different way. So I'll walk you through that how do I develop this new approach, or how do I implement this approach in the field of sepsis. So what's new currently right now we are going to talk about is that how we have understood the diagnosis much better than what we have, even with the same parameters what we have been used something like 15 years down the line is still being seen as a gold standard till date. And how do we treat these babies? Okay, so now the treatment approach, the plenty of evidence have come up, so I'll walk you through that. So we'll go through this. I'll try to introduce you that what kind of approach we are going to take. Then we'll walk through the all parts of approach like initiation, continuation, exit strategy, and few new things about the adjuvant therapy. Introducing the ideal infection marker. This is an exam question to all the residents. Okay, everybody is going to ask you, and still the chases remain elusive. So kind of we want the sensitivity and negative predictive value of around 100%, specificity of around 85 or more. We need to have well-defined cutoff so that what I do and what you do and what everyone else do can be comparable or should be comparable. It should be able to detect infection at an early stage, not when the child starts bleeding from everywhere. Okay, so we want to pick up when the things go out of hand. It should be able to differentiate between different type of pathogens, something like viral versus bacterial. It should guide our antibiotic use also, that what type of antibiotic I should use for what duration. And monitor progress of the treatment, so that if I do it serially, I should be able to know that yes, my treatment is going in the right direction, my treatment is going in wrong direction. And yes, I should be able to know the prognostication that, say for example, for an X value, if the parameter beyond X value, yes, there is nothing going to work beyond 2 drops of Ganga Jal. So I should be able to know that yes, what my test results are. Simultaneously, for a lab to run this kind of a test, it should be a stable compound. We should have adequate time window for specimen sampling. So from that moment we pick up or want to investigate sepsis and moment the lab report comes, in between there should be a window of time should be there with us. Volume of specimen should be small. Method should be very easy. Turnover time should be very small. And it should be low cost so it can be generalized. But tell you, we all know this line, we all know this parameter, but the chase of finding an ideal marker has still remained elusive. Okay, so now what we are trying to what we have tried an approach is to fit the old wine in a new bottle. Okay, so now we know how to use this instead of just ordering them blanket. So we'll do that. So, but when we work up for sepsis, we hate it. We don't want to do it, isn't it? Because these are the 5 reasons why we hate doing it. First thing, there is no glory in doing it. Okay, somebody tells you to work up for sepsis, shit man. Most of these workups happens at this nice glorious time of when the consultant is also sleeping and the resident is also sleeping. Okay, and the baby knows that when you are sleeping, he'll throw at apnea at that time only. Okay, so by the time you come in the morning, bloodletting must have happened. Drawing a blood is a difficult task. Okay, it might be easier to draw blood from an earthworm than to draw from a 24-weeker. Okay, and lab sometimes we call our pathologist Dracula. No, this is insufficient sample. Okay, so that's how it happens all the time. When the blood culture is negative, we all ignore it. No, baby was very sick. No, I need to give antibiotic for 10 days. So that's how our approach is. But if you want to do it, then why did you send it? And this is universal truth, that probability that lab will lose the specimen is inversely proportional to how difficult it was and how critical it was. Okay, and invariably lab will lose it. Okay, so these are why we hate doing it. Okay, so we'll go to that how to come out of it. Ultimately, at the end of the day, whatever your lab parameters say and whatever the clinical conditions say, we became cavemen and ask each other, second opinion, what do you think? They say, maybe a sepsis. And we go as per the Lok Shahi Tantra. Out of 3 of my friends, 2 are saying sepsis hai, I'll treat it. Okay, let all my knowledge go to hell. So we come out of this caveman approach, okay, and make it more and more rational. Okay, by definition, a rationalization means that I have a method in which I can do systemic selection. Choices are given to me, and these are based on reasons and fact. They are not just like that how come up. And I do employ a series of analytical steps so that I can choose a particular course of action beyond out of so many choices available to me. And then I keep reviewing it, that what are the facts coming on, what are the continuing observation, and what are the outcomes. Okay, so mainly rational approach is nothing but an initiation. How do we continue things, and how do we assess the exit strategy? So we'll go these things one by one. So how do we initiate? Okay, and sometimes we don't know why do we initiated it. Okay, and this is how is it? No, you one fine day you start reviewing the drug chart, you come to know, shit, piperacillin is going on. Who told you so? Okay, and it was the 10th day of piperacillin. So that's how it always happens. This is a universal thing in adults pediatrics. Okay, the scores which is most on the top of it is lack of appropriate knowledge that why I am giving this antibiotic. Okay, desire to meet patient demand, fear of clinical failure. You are being a hotshot neonatologist. Yes, you cannot go wrong. Okay, peer norms, marketing influence. Yes, and these kind of factors which influence our antibiotic practice. But truly, we do have some spurious indication also of starting antibiotics, isn't it? Something like a baby was outborn, not delivered in labor room, baby was premature or low birth weight. Yes, those babies should by having a weight of 1.8 kg, you are bound, you are destined to receive cefotaxime for 5 days. End of the story, whatever you do. Okay, presence of some or the other risk factor will tease it out. Some intervention, no, baby received 30 seconds of background mass, let me give him antibiotics. Okay, expected long stay, or maybe baby had some or other symptom. So basically we don't trust our colleagues. Okay, we sometimes start antibiotics, no, baby has transferred from this gynecologist, don't let me start antibiotics. Okay, baby has come from Samir's unit, and miropenam de isko. So that's how we decide sometimes. Plenty of time we don't trust ourselves, that yes, my care is going to be the top notch. Okay, we start covering our loopholes with antibiotics. That should not happen, and sometimes these kind of antibiotic indication are also justified. Okay, a beautiful girl starting an antibiotic, yes, I will not have a courage to deny it. So how do we initiate this thing in early onset sepsis? Basically for early onset sepsis, we want to rule out sepsis. We don't want to diagnose sepsis. Okay, so your process should be that you should try to identify risk factors, perform a careful physical examination, make an estimate that what are the probabilities of this baby having a sepsis, order the appropriate lab test, and try at the end of the day try to answer the question that who needs antibiotic, whether still this baby needs an antibiotic. So for an asymptomatic baby, basically these are divided into mainly 2 categories. Some who are born with some parental risk factor, some without risk factor. Out of this, we ourselves designate them into either high risk or low risk. Okay. Ask yourself, are these the risk factor we are talking about? Mostly encountered. That baby has some premature pre-labor rupture of membrane for more than some duration. More so that baby was preterm. More so this baby required some resuscitation. Okay. But look at the incidences. Something like 1%. Out of 100 babies, maybe one baby may be having it. Here maybe 5 babies having it. Here maybe 3 or 4 babies are having it. Okay. So still we are unnecessarily treating those 97 to 99% of the babies because we are sort of feared of this perinatal risk factors. We'll tease it out even further that rate of sepsis according to gestational age, look at this, around 34 weeks and after 42 weeks they have some rise. Okay, practically it is around 0.5 case per 1000 live births, that is practically negligible. Okay, so we sometimes end up treating premature babies unnecessarily. Same way for duration of rupture of membranes. Look at the incidence of cases per 1000 live births. Okay, where you can see an exponential rise, something like more than around 2 or 3, that happens only after 40-45 hours of duration of rupture of membranes. Before that, nothing happens. Okay, before that the probability is something like 0.5 case per 1000 live birth or 1 case per 1000 live birth. Okay, so we are not actually going to treat it. Same way, if we see maternal fever as a marker of chorioamnitis. So till mother develops around 101 or so fever, the rise of sepsis is not huge. And in term babies, chorioamnitis is the only risk factor which is supposed to be taken into account, and the fever is the most important marker. So mother developing 101 fever, okay, the case still the probability of sepsis pretty stays low. Okay, but we all know that these risk factors, they don't come in isolation, they come with other. Okay, so they are additive. So the way our enemies have pooled together, we pool our resources also together. Okay, so we try using the adjunctive test or some what we call rapid diagnostic test so that we can diagnose it. Okay, so if we raise the standard cutoff to 1715 ANC, go up little bit on IT ratio, and we combine all these things together, the positive predictive value still is pretty low. So say for example, even my sort of sepsis screen is positive, still I am not identifying a episode of sepsis. So the predictive value or positive of this child having sepsis is pretty low, even though my sepsis is positive, something like only 27%. Okay, but if my tests are negative, I'm almost surely excluding them that this baby is not having sepsis. Okay, something look at the negative predictive value of practically all the parameters, that's something like around 96 to 99, this 99 to 100, 98, 98, 97. Okay, and I deliberately have put a reference here. This is a very nice article and gives an insight of not going on the hi-fi funda level test and using the permutation combination of simple tests what we routinely do and routinely use and routinely interpret. But the sad part is we are the deedest part of the medical fraternity. Neonatologists are the most deed people, and whatever we do, we use single or the combination. If we want to give antibiotics, nobody can stop us. Okay, so whatever we do, it has failed to stop clinician from withholding antibiotic if we suspect infection. Okay, so what do we do once we have started this thing? See to it that whenever the child is asymptomatic, the best predictive value, even though they are pretty low, maternal temperature and gestational age are the better predictor than anything else. If the mother has an epidural anesthesia, which is very common nowadays, almost 1/3 of the mothers do develop low-grade fever, okay, for 24 to 48 hours. And if you are using the research test like interleukin 6, they are going to be elevated, okay, which start getting elevated within first couple of hours after baby acquired sepsis. So see to it that you don't interpret interleukin 6 level if the mother has an epidural and more so fever. Okay, so practically there is no role of sepsis screen because it has not shown to deter us from starting antibiotics. Positive predictive value is so low so that we are not diagnosing it. With intrapartum antibiotic prophylaxis, which is the only good thing antibiotic overuse has done till date, that many risk factor has got modified and they cease to be risk factor anymore. Plenty of time, no intervention is also a best intervention. Now what to do for symptomatic babies? Okay, it sometimes feels unethical to us that baby is symptomatic, yes, we need to give antibiotics. Okay, whatever maybe the justification is. So if the child is late clinical signs like this, like scleroderma, shock, bleeding from everywhere, you don't have an option but to give antibiotics, even though you have an alternative explanation available to it. Okay, you need to give. But the child may not need antibiotic in spite of being symptomatic. That baby was clean, practically an iatrogenic delivery, and baby doesn't have any pneumonia, and we have an alternative reason to explain whatever the symptoms are. So those babies may not need antibiotic even though they are presenting late after 72 hours of life. I've tried applying some parental risk scores for symptomatic early onset babies which are going to present in this IIP Neocon in Maharashtra. That the antibiotic was started in all symptomatic babies, but we hypothetically tried applying a parental score, that if we score and start applying it to symptomatic babies, what has happened. So score, there is no significant difference in the proportion of correct decision. Rather, the score could take few more correct decisions in probable sepsis. So yes, that's a new era in which we may have in future predictive model in which we can predict sepsis even in symptomatic babies by some algorithmic scoring. For late onset sepsis, yes, you need to identify whether the child has low probability or high probability sepsis. In low probability, yes, you should be willing to withhold antibiotic if the screening is negative. And again, the purpose is to rule out sepsis, not to rule in. We are convinced about the diagnosed sepsis that puts the child in high probability, yes, you need to give antibiotics. And even those negative sepsis screen will not alter the decision of starting antibiotics, and these are mainly late clinical signs. Okay, child with scleroderma, shock, bleeding from everywhere, DIC, so like that. So now we have started antibiotics in spite of doing all this. Okay, how do we continue it? Okay, start generally with first line antibiotics. First line antibiotics are into which the antibiotics are generally, bacteria are generally sensitive. Second line in which they are mostly sensitive. Third line they are almost all the time sensitive. Okay, the percentage wise it goes like something 60 to 70, around 80 or 90 to 95. Reserved drugs are drugs which are used for special circumstances only. They are generally same for early onset, late onset sepsis, but they cannot be generalized for all units. You should have your surveillance, microbiology data, and then you should try to tease it out that what kind of antibiotic regime you want to use, and mainly it depends upon your patient population also. Okay, how do we escalate antibiotics? Okay, sometimes yes, for our whims and fancies we do escalate our antibiotics, isn't it? So wait for at least 48 to 72 hours of before escalating antibiotic if clinical improvement doesn't occur. We sometimes fall into trap about using quantitative CRP serially using as a guide. Our clinical judgment is equally good. If you feel the child is improving but the CRP shows some jump here and there, you need not to escalate antibiotics. There are exceptions in which you bypass the first line antibiotic in which the child is extremely sick, of it deteriorating very rapidly, and the survival beyond 48 hours is pretty questionable. Yes, you can start straight with second line antibiotic, but take this with a pinch of salt. Don't go overboard with it, because I have received babies who come at 48 hours of life and had received 8 antibiotics till date. Okay, so don't go overboard with it. Okay, child is deteriorating fast, so let me change antibiotic every 6 hourly, 8 hourly. Please don't do that. About the blood culture has still remained the gold standard for diagnosing sepsis, but 1/4 of the infants have very low bacteremia, mainly because of intrapartum antibiotic use. If we expand our age limit to 2 months, almost 2/3 of the babies has colony forming unit which is less than 10. That is pretty small colony count. So if we increase the blood volume of sampling, yes, it does very good thing to us. So if we increase the blood volume from 0.5 ml to up to 2 ml, we are able to diagnose almost 99% of the babies if the colony count is around 4, and almost 80% of the babies if the colony count is less than 1. So given a choice, your choice of blood drawing should be at least 1 ml, if not 2 ml, when you are sending a blood culture, so that yes, you can justifiably around 90% of the babies you should be able to pick up. Lumbar puncture should be done in all symptomatic neonates, okay, but there could be some exception. But decision of LP should not be based on your sepsis screen or blood culture result. Okay, let me wait for sepsis screen result to come. If it is positive, I'll do it. Okay, let my blood culture come positive. If the blood culture is positive, let me do it. Please don't, because look at this. Gram positive bacteria, they clear within 36 hours. So if you delay your lumbar puncture by 36 after starting antibiotics, you are not going to get anything on CSF culture, which is very important test for us. Gram negative bacteria goes off in 5 days. Okay, so by the time blood culture comes and you decide to do lumbar puncture, done, you have missed the boat. And concentration of glucose is not significantly altered by traumatic lumbar puncture, so still you can rely on it. So we'll see what are with different cutoff, what are the post-test probability of a child developing a sepsis. That for WBC count 1 to 8 to up to maybe 100, so only more than 100, glucose less than 20. So taking different parameter into account, look at this post-test probability. Okay, generally it is defined as if the probability is less than 3, you should not treat. Okay, if the probability is more than 10, you should treat. What would be between 3 to 10? It's your clinical judgment. Okay, given a choice, are on the side of treating it than not treating it. Okay, so something like these 4 parameters of WBC count of 9 to 21 to up to 100, glucose level less than 20, or maybe protein more than 120. Yes, if these are there, you should treat it. If these are not there, you should not treat it or rely on your clinical judgment of whether you should want to treat the child for meningitis or not. Okay, so now we have started antibiotics, we have continued it, so now when to stop it. Okay, so this is a must have, you should have it. Okay, you should be like this when the blood culture report comes. Okay, when the blood culture is sterile, you should be jumping with joy. So what to do with it? In probable sepsis, generally defined as some clinical symptom and some parameter of sepsis screen positive, this is generally a probable sepsis. So this is a nice study which is done by my senior, that short course, that is 4-day versus 7-day course of IV antibiotic, which one is better. So if child doesn't have any meningitis and blood culture is sterile, so just with some clinical signs and some sepsis screen parameter positive, giving antibiotic only for 4 days is perfectly fine. You need not to continue for 5 days or 7 days. Okay, so there is no difference in treatment failure between 96 hours of treatment and 7 days of antibiotic duration. The 4 days are perfectly fine. As soon as you get your 48-hour incubation report, stop antibiotics. When you get the blood culture proven sepsis, these are the things which makes you take that report with a pinch of salt. That rule out contamination, like growth only in 1 bottle if we used to send it in 2 bottles when I studied. Growth of a known non-pathogen, and growth is very delayed, especially if the mother has received antibiotics within last 72 hours. Try to use narrow spectrum antibiotic. Use single sensitive antibiotic with an exception to Pseudomonas. Okay, so single antibiotic should do unless until it is Pseudomonas. And always be aware, it's good to read that our old most boring book of Anant Narayan once again, to go through the microbiology thing and try to be aware about the in vitro and in vivo sensitivity. Overall, if the child becomes fine by day 7, okay, even blood culture positive sepsis, 10 days antibiotics are fine. Okay, but the clinical remission, the child should kind of become completely asymptomatic by around 7th day, then 10 days antibiotic is fine even with blood culture proven sepsis. Exceptions are staph, okay, 14 days 100%. Deep-seated infection, yes, you need to prolong antibiotic for 2 to maybe up to 4 weeks till it gets cleared off. And it is not recommended that you do a CRP. If the CRP comes negative, you stop antibiotics. Okay, please, that is not to be done, because CRP is not a marker of infection, marker of inflammation. Okay, so maybe malnutrition can keep the CRP a little high, and you keep prolonging antibiotic because of that. That should not happen. In adjuvant therapy, okay, there is nothing much, still IVIG, still being tried, no improvement in hard outcome. So unless until for exceptional cases, it is not recommended. Colony stimulating factor, there are no supporting evidence much. Single volume extended transfusion come into picture for early, as an early therapy for the child who develops late clinical signs like some sclerema, like shock. The single volume extended transfusion has done something good, but still it has not changed the mortality of duration of hospital stay. Yes, it has still not changed the hard outcomes, so still it can be used only as a sort of research thing, or maybe an exceptional case if you want to try. So predictive adjuvant therapy, it's nothing. Okay, we still need to generate evidence for it. So take home message is that the new thing in sepsis is the way we see it now. Approach is more rational. We have understood our old friend much better. Always trust your knowledge. Okay, believe me, babies do read textbooks and come. Okay, so they know the recent evidence and they behave nicely if you trust your own knowledge. Don't let your whims and fancies cloud your judgment. Okay, use sepsis screen not to diagnose it, but sort of undiagnosed sepsis, and always an exit strategy. Okay, you have fallen into a trap, fine, get out of it. Okay, because continued antibiotics have so many issues. Okay, so always have an exit strategy. Okay, here I'll end, and I'm grateful that the audience has not turned out to an audience like this. Thank you. I'm more than happy to receive questions.